Dr. Olivier Hagen will be moderating, and then we'll have a very informal discussion with, in particular, Dr. Nema Kaseja after the presentation. So, Dr. Hagen, can I turn it over to you now, please?
Okay, first of all, thank you very much to invite me just to moderate the session, and I'm very happy to be part. As you know, the COVID-19 is currently a pandemic that affects lots of countries worldwide, and the big challenge is also how can we manage to treat those patients with limited resources. And Lionel Dumont make an excellent scientific review of the current level of science now, and we will have some explanation and some option how to make it better. Lionel, it's up to you.
Okay, so I think I can start with this lecture. So please, next slide. Okay, so we will just review today what are these different options for oxygenation support during COVID-19 respiratory distress, and especially adapted to low resource hospitals. And we will have this lesson learned from the literature, general literature, and also, surprisingly, from the top of the Kilimanjaro Mountain. Next slide, please. Okay, so I am an anesthesiologist, and I work in the Geneva University Hospital. So I work in a place where very unlimited resource. And I also work in many different countries, in many different settings like disaster or rural hospital with low resource. And when I was involved in the treatment of patients with COVID-19 in the Geneva University Hospital, I was really impressed to see how much material, how much human resource, how much skills we did need for treating this patient. And really my question, what will my friends, my colleagues working in low resource will face these terrible things? Next slide, please. And actually, it's already the fourth time we are doing this webinar about COVID-19 and oxygenation support. We did first in April, mid of April, after beginning of May, and after end of May. And at that time, we did not get so much information concerning the treatment. It was still under process. The research was still under process. And it was more a food for talk lecture. And we were focused on different alternatives to mechanical ventilation for COVID-19 ARDS, especially with limited resource. But since that, we have more important knowledge, and some of our colleagues, like the WFSA, just published some guidelines for low resource settings. So it's a little bit different now. And next slide, please. Okay, so let's go back to the base. Yeah, what are patients dying from during COVID-19 infection? Actually, you know that the lungs are the organ most affected by COVID-19, and acute hypoxemic respiratory failure necessitate this oxygen and ventilation therapy. As you see here, you see on this picture, you can see that this is the normal alveolar system. And when the virus goes into the alveoli, it creates an inflammatory response. And the inflammatory response goes with liquids and exuda, and then completely fill up the alveoli. And then the gas exchange cannot work adequately. And then that's the reason why patients are admitted in the intensive care unit. And that's the reason why the mortality increase, because it's related to the complications such as mechanical ventilation, adverse effects, and it's this whole syndrome is calling ARDS. Next slide, please. Well, the cause of hypoxemia in ARDS is essentially due to alveolar instability and inactivation of surfactant. Let's make some comment about here. You can see here this part of the alveol is the normal one. It's full of gas, And here you have the blood flow from the lung, and then the gas exchange can be perfect at that level. Unfortunately, during ARDS, the alveolar is full of liquids, and then the gas exchange cannot be perfectly done at that time. And then that leads to what we are calling mismatch of ventilation perfusion, or even shunt, meaning that part of the blood goes into the lung without being without any gas exchange, and this leads to hypoxemia. It's a little bit like the alveolar are collapsed, and the only treatment to uncollapse is to apply a PEEP. A PEEP is a positive end expiratory pressure, and that can promote reinflation of the collapsed alveoli and improve this ventilation perfusion ratio. Next slide, please. Okay, so what is important to know is that there is no real treatment for ARDS. It's only, we just have to wait that the lung will cure by themselves. So it's just a supporting treatment while the lung heal, means it needs intubation, mechanical ventilation, high PEEP, and low tidal volume. This is something very, very sophisticated, needing ventilator, complex mode, prone position, sedation, medication, many things. Fortunately, I will not go into details, but the mortality related to COVID ARDS is improving. In the beginning of the epidemic, we got numbers, incidents such as 88% of mortality in a JAMA publication reported by Richardson. And now the last publication from 2 weeks ago, coming, for example, from Georgia, decreased to 30%. And the explanation was that probably by increasing the knowledge during this time, the last 2 months, we can be more prepared and be less iatrogenic and have better teams to take care appropriately of this intubated patient. Just for finish with this, the recovery from ARDS, when the patient recovers, usually it's after 7 or 14 days of ventilation. It needs most of the time tracheostomy, and you have patients with a lot of functional disabilities for years. So it's a very severe disease. Next slide, please. Sorry. So according to this, there were previous publication for a guideline for treatment of COVID-19 ARDS, but fortunately for us, we have new guidelines published that seems to be adapted to the limited resource. And then next slide, please. I would like to review step by step what's up. Oh, sorry, this is not really exactly the, well, let's talk about the transport ventilation. Next slide, please. Okay, the first proposal is to use transport ventilator and anesthesia unit. You can see here, this is anesthesia unit and this is ventilator transport. Next slide, please. But no. Previous slide. Yes, but what I say is that to ventilate an ARDS COVID patient, you need a Formula 1 ventilator and a pilot and a team. You don't need just an anesthesia machine or a transport ventilator or an improvised device with an improvised pilot. So I mean, once you decide to intubate the patient, you have to be with the best team and the best material. So there is no possibility of expecting a good outcome if you are using transport ventilator and anesthesia unit. So the next point is that they propose to share ventilation. I mean, to split ventilator and instead to ventilate only one patient with a ventilator. They were proposing to split and ventilate several patients with one ventilator. And then, okay, so it's, and then, yeah. So what happened with this system? you can find on the internet at least 1 million view for some YouTube explanation on how to ventilate, how to split ventilator, and a lot of kind of hysterical and desperate attitude concerning the fact that may be the only alternative for saving people. And it was really it was a big buzz in the media. But finally, when you look clearly at the literature, you just find only some paper how to do the splitting, but there is no clinical data, no case report, and even there is strong warning by the society, anesthesiological society, critical care society from the United States, strong warning against this kind of practice. So I feel that it's not a good idea to try to use splitting ventilator, especially in the field of limited resource. We continue. Okay, so the next point was improvised CPAP to replace invasive ventilation. Then you can find this improvised CPAP. It was calling the Easy Breath Decathlon Surface. It was a snorkeling mask that you can use because there is no leak. You can use it if you connect this snorkeling mask to a non-invasive ventilator. You can have some, to some extent, some continuous positive airway pressure, and by this way you can keep the alveoli a little bit more extent. Unfortunately, once again, there is a strong warning concerning the medical recommendation goes against this third use case, and I am very open-minded, but to this day there is no study, no randomized control trial, no observational study, and no case report reporting anything clinical use with this mask. There is only press release and YouTube video, and I have some testimony for my friends and colleague from DRC. We will talk about this a little bit later. And if we go, we continue the list, the bag valve ATT, it's a very useful device. It's an ambu bag. In someone, you can find a PEEP with a good valve, and it will probably be useful if you use it for very short-term periods. But if you want to use that as a continuous positive airway pressure for a long time, it is completely impossible to use it. You have to fix that on the face of the patient, and it's very uncomfortable. Finally, the only real CPAP and strong and reliable that you can use is that is calling the Bussignac CPAP valve. I check on internet, it's cost $100 US, and it's completely you cannot destroy this. It's very strong, and it's working like this. It's a kind of valve. You put oxygen into this valve, and the patient is here. When he is inspirated, the oxygen flow just facilitate inspiration, and when the patient expirates, there is kind of break here, and then the gas is just the gas goes slower, and then you keep a positive airway pressure. This is probably the only real improvised CPAP that can work. There is a lot of reports, studies, even randomized controlled trial telling us that it works. I did not see anything so far testing in the field of COVID-19. The only problem is that it needs oxygen, but in this disease it needs oxygen. Finally, the last point was the use of portable oxygen concentrator. You have a picture here, and also cylinder. The advantage of the concentrator is that if you have electricity, you have oxygen as long as you want. Unfortunately, there is no electricity, you don't have oxygen. And the cylinders, of course, are very useful, but unfortunately, when they are empty, there is no more oxygen. And you can give oxygen through this kind of device. I mean, a probe or a mask, everything is working. And the last point we have here is the early use of prone positioning. There is, to this date, about 20 small study, essentially retrospective and prospective, counting about 250 patients, and that demonstrates a very fair efficacy by improving the oxygenation, decrease the rate of intubation. What is the mechanism? Look at that. If you look on the, if you are on supine position on your back, the blood flow is more important in the back from the anatomical point of view than in the ventral part. And unfortunately, most of the dorsal part of the lung is collapsed. So if you put the patient in prone position, it's exactly the opposite happen concerning the airway. I mean, the alveoli who were collapsed in dorsal position because of the gravity just are more inflated. And since the dorsal part, it's still more perfused, the blood flow is more important, you improve significantly the ventilation perfusion matching. It's not to decrease the rate of intubation. Unfortunately, the position is a little bit uncomfortable and it needs at least 12 hours, even if the oxygenation improves quickly, it needs at least 12 hours to be reliable for a long-term and improved outcome. It's not easy to put a patient on a prone position to be very comfortable. You can find a lot of information and video demonstration there. I just had 2 days ago, there was a publication. It was the preliminary report from the recovery trial. It's a pre-publication, so it's not yet completely peer-reviewed, but for the first time, it's a real multicentric randomized controlled trial. It's not blinded. It was started on 19 March, it finished 8 June, concerning the effect of dexamethasone. And this is very interesting because dexamethasone is something that we can find everywhere, especially in low resource setting. They were using 6 milligrams a day for 10 days. The methodology, the concept of the study is very well done. So the results were mean age 60 years old, 36% of female, and most of the patients, more than 50% were with comorbidity. And at randomization, the patients were randomized when they were entering in the hospital. We had 16% of the patient already under mechanical ventilation, 60% received oxygen, and 25% did not receive anything, means they were only with fever, headache, but no respiratory symptoms. The results are very interesting. The overall mortality decreased significantly in the dexamethasone group. I mean, we were 21% of mortality vs 24%. It's a 28 days mortality. More interesting, the patient under mechanical ventilation, you have a significant decrease of mortality in the dexamethasone group. This is exactly what you see here. It's a very important, decrease. And interesting for us with limited resource, there is also a decrease of mortality by 20% in patients only receiving oxygen. I mean, the mild and moderate case of COVID with pulmonary failure will benefit from this dexamethasone. And there were no effect on the people without any symptoms of any pulmonary or respiratory symptoms. Very interesting. So finally, is there an alternative to mechanical ventilation to give finally enough oxygen for the patient to pass this difficult part and recover? In our resource, I was telling you, in the best case scenario, you have 30% of mortality. So you will not do better than this so far. And in low resource, there is no many option. I finally explained you that a lot of these recommendations are not really, the feasibility is not really easy or proof or not dangerous. However, what we have oxygen through tank concentrator. We can put patient in prone position. We have pulse oximeter that can measure the oxygen saturation. Most probably in Africa, we have younger patient, mean age 19 years old. We can improvise CPAP if we can have this Buzignac valve. Most COVID-19 patients admitted to hospital have mild to moderate. I remind you, only 16% of the patients in the recovery trial were already intubated. Dexamethasone is known to be efficiency in severe case. And in Western experience, it was described as hypoxemia was described as hypoxemia, happy hypoxemia. So look like the guys are happy. It's not really true, but means they are not agitated and they are quite comfortable. So we were thinking that most of patients can be managed fairly just with this. However, since that, we got this experience from the Yemen and from DRC, and finally, what happened in this situation? I mean, always when you do a plan and when you look at the reality, it's not always the same. Let's take point by point. Oxygen. Quickly, there was shortage of oxygen because when the patient is in shunt, I mean, when the alveolar cannot participate to gas exchange, you can increase the oxygen to 15 liters to 50 liters. It does not change anything. So there was quickly a waste of oxygen because of misunderstanding of the physiology, pathophysiology. And then in that situation, prone position will be very, very, very useful. Pulse oximeter, my friend from Congo, they report SpO2 around 20%. We don't know what we measure. Below 40%, we don't know what we measure. I was thinking of the willingness of doing well, but when you have too much patient, and that's exactly what they experienced in Bukavu. It was a short time, but during short time they received like 20 patients, and it was very complicated for them. The improvised CPAP, the Decathlon mask, was in the protocol of Bukavu. I was very surprised, but they were completely unable to tell me if it was with any efficacious or not. I was thinking that the patient should be younger. Unfortunately, their experience, they had many old patients with diabetic disorder. So once again, not easy. And most of the COVID-19 patients admitted have mild to moderate. They told me that the patients were waiting so much before arriving to the hospital that many of them died within 4 hours after their arrival. And they tried to intubate patients because they did not know really how to manage some complicated and very hypoxemic case, and they experienced 100% mortality. So they did not try the dexamethasone because the preview publication was updated only 2 days ago. And I was talking about the happy hypoxemia, and they report me that all their hypoxemic patients were very, very, very agitated. And then I think finally the protocol needs to be adapted according to. The second point I wanted to mention is oxygen saturation above 93% is really necessary to survive, and it's another cause of hypoxemia. It's the low inspirated oxygen content at high altitude. So it's lesson learned from the top of the Kilimanjaro. At that altitude, you can expect oxygen saturation around 70%. And you see this guy is in top. He's not dying. He's hypoxemic, but he's not nearly to death. Why? Because humans tolerate hypobaric hypoxemia very well, essentially through complex mechanism of compensation and acclimatization. But just for you to imagine, at the summit of Everest mountain, the P oxygen partial pressure of oxygen is around 25 to 30. That corresponds to an oxygenation SpO2 oxygen saturation at 40 with a PCO2 at 7 millimeters of mercury. Let me show you an example. This guy, it was during an experience we did at 4,600 meters. This guy has an oxygen saturation of 44%. We just gave him oxygen, and 2 hours later, he was ready to go down in a more in an environment with more oxygen. So you can survive with this very, very low oxygen saturation. So what we can do from this experience, that hypoxemia does not necessarily lead to hypoxia and lactate acidosis, that hypoxemia and hypoxia may be very well tolerated, that severe hypoxemia and hypoxia may recover very well. And the question is SpO2 70 to 80% a problem? It's a little bit provocative, but no, in healthy patient, in healthy individual for short-term periods, certainly not, especially when the installation is low. But what about in COVID-19 patient? And of course, that's the deal. Hypobaric hypoxia is not ARDS hypoxia, so because there is no concomitant disease. But when you look at the ARDS recommendation for level of oxygen, there is no formal guideline to an oxygenation target in ARDS. So can we accept and tolerate some severe level of hypoxemia? It's clear for many teams, it's no. And in the field of the COVID-19, they suggest starting oxygen when the oxygen saturation is below 92, and they recommend starting oxygen when the oxygen saturation is below 90. And it's a publication, an old publication from the American Journal of Critical Care. The time spent below normal saturation value was really correlated with decreased cognitive performance. As much you are hypoxemic, as lower are your cognitive performance if you are covered. But other teams say, yes, you can accept and tolerate some level of hypoxemia. And this was published 2 weeks ago in the field of COVID, and Tobin said, once again, in the American Journal of Respiratory and Critical Care, that sometimes tolerating lower arterial oxygen saturation is appropriate. That was done in the field when we were thinking that we were intubated too much people. And why they are saying that? Because the evidence of end organ damage is difficult to demonstrate in patients with PaO2 above 40 millimeters of mercury, equivalent to an oxygen saturation of 70%. So I don't want to say that you have to keep your patient hypoxemic, but if you don't have any choice, you can probably tolerate a little bit more of hypoxia. So the take-home message, let me remind you in this yellow box that in April 2020, when you were looking at the WHO guideline for a low resource, they were talking about endotracheal intubation, mechanical ventilation, and support if oxygen saturation is below 93. Already this has been adapted more to low resource. We are not talking about endotracheal intubation and mechanical ventilation in first line. There are alternatives to intubation and mechanical ventilation. Oxygen and prone position spontaneous ventilation has demonstrated efficacy. Dexamethasone 6 milligrams per day if patient need to oxygen has demonstrated efficacy. And don't forget, as we just mentioned, that human may tolerate hypoxia much more than expected. The subliminal message is that if you have a patient that do not respond to oxygen, to prone position, but still alive with 75% of oxygen saturation, if you intubate them with low resource, you will kill him. But maybe you have more chance not to intubate him because he will support this. I cannot say that, I have to mention that unfortunately COVID-19 is not only about respiratory. We can do webinar about coagulation, renal impairment, neurological impairment, dermatological. There is many trouble. And of course, protect yourself, safety first, when you are in contact with this COVID-19 patient. So in conclusion, I think with limited resource, you have to think different, but think different that are simple, safe, and who demonstrate efficacy, not making experience. It does not work, at least so far. But I really think that COVID-19 patient with respiratory distress in low resource environment may have better chance to survive than expected when mechanical ventilation was supposed to be the only option for oxygen support. Even here in Western country, we will probably not intubate as much as we did for at the beginning of the pandemic, beginning of March. And when we are talking about oxygen support, what has been shown to demonstrate efficacy in the literature is oxygen, prone position, and dexamethasone. And I believe that you can consider, if you don't have enough oxygen or if you don't have any other alternative, that oxygen saturation lower than 92% without any problem. Thank you very much. I'm sorry for this confusing beginning, but I think finally we have the message. Thank you very much. If you have any question, or I think maybe Nima will do something, or Olivier, yes, please.
Yes, Lionel, thank you so much for this very comprehensive review and also the different points as you highlight. I think there is something very important is about the ethical consideration. To use the improvised devices that are not proved as efficient and are not proved as adapted to medical care. Ask also the question about do we arm? Do we make? Are we going to treat the patient in the best way? That's why it's very important, even if we are in a pandemic and we need to treat quite a lot of patients, to remain within our scope of practice and also within our scope of competence. And that's something very important. At the end of the discussion, I will recap with some points that I just highlight. But I think maybe Neema would like to add something. And after we will be ready for questions.
As you can see, I'm in the field in rural Kenya, and I apologize in advance if the connection is not so good. So thank you so much for that excellent presentation. You really highlighted some of the things that we can do. What I've found here in the field is that we are overwhelmed with challenges. We are overwhelmed with what we do not have. And I think key to the response is leveraging the resources that we do have. And so now we've just finished our baseline assessment in Siaya. Siaya has a population of 1 million, 2 ventilators for that population of 1 million, no training in critical care. And at the community level, we're at the beginning. So there've been 13 cases. All of them came in from other countries or from a different county. So we're yet to see significant community transmission, but that also means that we have a good chance with containment and aggressive prevention. And so what we'll be doing in the next few weeks is really leveraging the assets that are present. And the assets that are present are youth, as Lionel mentioned, the population structure is quite young. Many of them are well educated, and because of lockdown measures are sitting at home, not doing anything. So we've recruited youth. We're working with community health workers. In Kenya, for example, since 2007, the government has adopted the community health strategy to make sure that every single household has access to essential health services. So today alone, we visited 100 households looking for cases of fever and any cases, any households presenting with COVID-19 symptoms. And we're also looking at behavior. Do people have washing points in their home? Are they taking in visitors from outside? Are they traveling outside to other counties? And which comes to our integrated approach in the end, because we will have interventions at the community level to make sure that there's aggressive containment and prevention. And then we will have interventions at the health system level, making sure that we're building critical care capacity, but adapted to the resources that are available. So we were quite excited about the Dexamethasone. I think that's the best news we've had so far. And we're also quite excited about other measures like proning the patient, providing oxygen, and supporting them through the infection, because if we can't really depend on ventilators because there are none. Thank you.
Yeah, I think you summarize very well the situation from the field, and that's, yeah, I think that's just confirm what we can find right now in the literature. What do you think, Olivier?
Thank you.
I agree. I don't know whether there are some questions that were on the chat, or because I think it's very important to get the question from the participant. But thank you so much, Naima, to get the feedback from the field, and I think we are completely in line with what you think.
One of the Dr. Hagen, one of the questions or comments actually from the chat was from a person by the name of Sonia Jajanin, and they were saying that they were having quite a lot of pressure to resist the improvised devices and these alternatives, because I think everybody nowadays can watch and hear that, oh, you have to be intubated when your oxygen level's going down. But as you have clearly pointed out, Lionel, that in that kind of setting, that could be very bad, actually, with such a high mortality rate. So maybe the three of you could discuss on ways to think about that. Oh, and Sonia said she's from the ICRC, so thank you for your comment.
Yeah, what I learned when I was I work for during I work in the intensive care of the Geneva University Hospital during the COVID period. Was we had like more than 62 patients intubated, and what I understand is that for treating this kind of patient, you need high level material and high level of skills. I mean, I take my example. I am an anesthesiologist. I can work in many places in the world, and I'm doing anesthesia every day in a university hospital. But when they transpose me in the critical care, I swear I don't have the level to treat this kind of very complex patient. And when you are using, because after the first 40 patients, the next 20 patients, we use the anesthesia ventilators. And the anesthesia ventilators, after 24 hours, you have problem. Too much humidity, not enough humidity. It's not the same ventilatory mode. You have to change the tube after 48 hours. You increase the risk of mortality related to changing the tubes, and we experience a lot of problem. And we understand. That's why I was putting a slide. When you want to ventilate, when you decide to intubate a COVID-19 patient with ARDS, severe ARDS, you need to have a Formula 1 respirator, a Ferrari, and you have to have good pilot, critical care doctor, specialists in critical care, and a good team of nurses and paramedics that can be manage this properly. There is no improvisation in this ARDS. It's not like at the beginning everybody was saying, yes, you just intubate, you wait 7 days, and after it's okay. It's not like this. It's a very complicated disease. The ventilatory mode are complex. Sometimes some patients need very high PEEP. Sometimes patients need to be on prone position. Sometimes prone position worse the situation. So Let's go back on the dorsal port. It's very, very, very complicated. So if you are in a low resource setting, if you decide to intubate the patient with an unexperimented team, a very simple ventilator, you have so low chance to make survival. The outcome will be so poor. And it's documented in New York. At the beginning, they report mortality around 88%. In China, they report very high level of mortality. And I was mentioning that now the mortality related to COVID-19 in intubated patient is decreasing. Why? Because we understand that we don't have to intubate all these patients, and the patient intubate must be managed by a real team, not improvised team. What do you think, Olivier? Because you stayed nearly 3 weeks in the intensive care. So you 3 months. So you know that.
No, I agree with you, Lionel. But the point is, we have to say that we learn a lot from our humanitarian practice, because even in our Western countries, we had limited human resources. As you mentioned, that you are anesthesiologist, you are not specialist in intensive care. And that's why we need to find another way to get enough staff to take care of the patient. That's why we had nurse anesthetists who have been employed as a nurse in intensive care under the supervision of a nurse specialized in intensive care. And we had anesthesiologists, as you did also. And in fact, we went through the task shifting process as you are doing, I would say, on a daily basis in Africa. That's why, for me, the impression I got when I spent 8 weeks in the intensive care in the Geneva University Hospital, that in fact, we face our humanitarian crisis. In fact, we decrease our level of care from a hospital 5-star to a hospital 3 stars. But we remain in a very high level of quality of care. Nevertheless, the fact that we need to adapt our level of practice, our level of care, puts lots of persons in a very uncomfortable position, because they felt that they had to adapt themselves, and even they were sometimes absolutely not comfortable and not happy, because we had some bed sore that start to appear. And in fact, if you are a health professional, when you had bed sore, the message is, in fact, you didn't make your job. And in fact, it was just an issue that we didn't have enough time just to make it. That's why, as you mentioned, we do not have to make a kind of do-it-yourself practice of medicine, but we need to adapt our practice with the limited resources as we had, but as is in most of the country with limited resource, they have on a daily basis.
Yeah.
Thank you, Dr. Hagen. One of the questions I wanted to direct that came in on our chat line was for Nema from Janet Martin. Impressed by the limited person-to-person transmission in Africa, what have been the measures used to prevent community transmission and nosocomial transmission? And I'll take that question a little bit further. What's the situation on the field for PPEs for your healthcare workers? And Nema, can you highlight some of that, please?
Yes, and sorry, I dropped off for a bit. So in terms of community transmission, so our baseline actually shows significant uptake of preventive measures. So close to everyone wears a mask. When we do our household visits, we do it outside. I wear a mask, the household member wears a mask, the kids wear masks. So we're seeing we're seeing a lot more mask wearing than in other parts of the world. We're also seeing hand washing stations everywhere, at the gate and at the door. I think we just realized that the health system does not have the capacity to absorb large numbers of cases, and everyone is just on the same page with regards to prevention. So people are washing their hands 5 or 6 times. They have hand washing points. They're not going outside. They're not accepting visitors, which is against cultural norms. And when they do go to the market once or twice a week, they wear a mask. So I think that has really limited community transmission. And what we're going to do is we're going to reinforce that message by feeding back these baseline results to make sure that these behaviors are maintained over time. With regards to PPE, we haven't had significant symptomatic cases. And so the 2 or 3 cases have all been dealt with in isolation centers, and they've been practically asymptomatic, so they've not required any medical care. But as we all know, that can change quite quickly. So the demand for PPE is being met at the moment, but that could change in the next few weeks for sure.
Excellent. There were a couple of good questions about dexamethasone. One excellent question about the African setting, because I think these studies were done in high-income countries, whereas in Africa, you may have more undiagnosed HIV, parasitic diseases, and the treatment with dexamethasone may be a little bit more complicated in that setting. And the other additional question was, is it readily available in most African hospitals?
So the answer is yes. I spoke to our pharmacist early this morning, and he was quite excited about dexamethasone, and he said he had a huge stock of it. So getting dexamethasone is not a problem, and it's affordable. I agree that we may not be able to generalize those results directly to the African population, and will likely need to adapt those results to the local context. Yes, there's a higher prevalence of endemic diseases such as malaria, HIV, and tuberculosis, and obviously we will be careful about administering steroids.
Yeah, I would like to add something concerning dexamethasone that was done in UK. So of course it's not limited resource, but I don't know if you remember the results. Dexamethasone showed efficacy, great efficacy in intubated patients for decreasing mortality by 30%, 35%. In patients requiring oxygen, it decreased mortality by 20%. It's less efficacious. And in patients with COVID-19 without respiratory symptoms, it's not working. So I mean, the idea is not to give dexamethasone to anyone. It's only for those who may require oxygen. So it's valuable. It's a valuable decrease of 20%, but it's a decrease of 20% of mortality. It's not a decreasing of 80% of mortality. So of course, if there is so concomitant disease more dangerous, or that can be worsening by dexamethasone, it should be think about. That's what I was telling you in the end. Think different and think for every patient different. Okay, dexamethasone is a new tool that has been demonstrated to be efficacious in some situation, and some patient will profit from this, and especially in Africa, and some other will not. So we have to just think about this.
Another question came in about to you, Lionel, about when would you start considering putting a patient in prone position, like SO2 readings? What stage would you want to start considering? Because it is a lot of work to take a sick patient and start rotating them around.
It's not difficult to put a patient, an unintubated patient, in spontaneous ventilation on prone position. I can do myself. It's very quickly done. And when you ask to a patient to do that, it's not complicated. So I would say as soon as the patient has a SpO2 below 90%, it means that something happened in the lung. And by putting the patient in prone position, you will improve the physiology of gas exchange into the lung. Okay, so I mean, the threshold for oxygen is 92%. And I did not have time to show all the diagrams, but when you put the patient in prone position, most of the case, there is responder and unresponder, but most of the patients are responder. You improve quickly the oxygen saturation. So as quickly as possible, as long as possible. And most of the case report management of prone position for about 4 days. I mean, when you read the literature about this, you understand that the respiratory failure, respiratory injuries will last for about 4 days, more or less. When the patient starts to be hypoxemic, if he's not intubated and if he don't die, it will need about around 4 days to recover. So during these 4 days, as much as possible on prone position will be probably benefit. But we are talking about 20 study with 250 patients. It's not a good large randomized trial, but this is indication. When I first do the first webinar with Nima, it was beginning of April. We had only 2 papers on prone position in non-intubated patients. Now we have 20, and there were 2 more this morning. So it's something that is increasing. People try it. The studies are a little bit different. Some are very enthusiastic, some are a little bit less. But in any case, there is always something improvement by this prone position.
Thank you. Maybe Dr. Hagen, there's a question here about I could direct this question to you, any role of anticoagulant or aspirin-like drug in treatment of COVID, particularly in the setting in Africa or Asia?
I think it's much better that you answer to this question of anticoagulant, because we in fact in Geneva we put patient under anticoagulation now, but because there is also an increasing number of emboli, pulmonary emboli and thrombosis. That's why I mean it's. But maybe you want to add.
Yeah, any situation of inflammatory storm just creates a procoagulant situation in the body. So yes, if you have any kind of prevention anticoagulation like HBP and heparin low
molecular weight heparin.
Thank you very much. It will be. But this is quite expensive, and this is maybe not available everywhere. Just heparin can be useful. Subcutaneous heparin could be useful, but the duration of action is not so long. And I would say, and concerning aspirin, the problem of aspirin is not really anticoagulant effect. It's more anti-aggregation. I did not focus really. I will speak truly. I did not focus my research on this, but what we were doing in Geneva is using anticoagulation systematically for all severe patients. I think if you have a mild or a moderate form of COVID, it's probably not that mandatory, but as far as you have a severe form, it is mandatory to use anticoagulation. Okay, for me, I don't know how much time do we still have, but and I don't see other question in the chat. Am I right?
Yeah, I think we've covered most of the questions.
Okay. because I would like just to come with some points. In one of the slides, Lionel, you mentioned the use of ventilator and also the limitation regarding, I would say, availability of ventilator, as Nema has shown, is very, very limited in some places. Also the shortage of oxygen and also the medication. But I think it's not completely enough. As you mentioned, we need educated staff, and educated staff is also a big challenge. But we need also power. And as you know, in lots of countries, you have electricity since 8 a.m. in the morning, sometime up to 2 p.m., few hours in the day, and that's all. You need also spare parts because your machine will be used after use, and you need also consumables. And those limitations are very difficult to manage. That's why I mean, to go with the use of ventilator, especially with limited resources, for me is not a good option. And if we take the issue of medication, especially with the neuromuscular blocker, we need cold chain. And that's also a big issue related also to electricity. Something which is absolutely essential for me is we are in a health crisis. And this health crisis is currently focused on COVID-19. But we don't have to forget that, in fact, we need to work within a health system as a whole. We need to not to forget that women will continue to deliver. And as you know, in lots of countries, there are, if we take the population under 15, there are sometimes for 40 or 43%, like in West Africa, 43% of the population is under 15. We have also patients with non-communicable disease, especially diabetes, hypertension, or COPD. We have also patients with communicable disease. And Nema was mentioning the patient with malaria. But I mean, malaria will kill also a lot of patients. And we unfortunately saw some organizations who, due to the pressure, reallocate their funds to fight against COVID. And in fact, they stopped the vaccination campaign against measles, for instance. And it's absolutely not something that needs to be done. You mentioned also the importance of the personal protective equipment for the health professional. In some places, it's very limited. And again, the most important remain the prevention. And prevention is something that can be done easily. You know, that's to go for social distance. Of course, if you see in the different, WHO will say 1 meter, other country will say 1.5, the other will say 2. Well, it is in between, basically to avoid contacts. It's a bit like as we did during Ebola. You know, Ebola, it was a no-touch policy, and it's we need to put some distance. Hand hygiene is also very difficult because the first way is to make it with soap as water, but there are lots of places where there is no water. That's why it's quite difficult. And if you can try to use the best way, the best way adapted to your situation, soap and water or alcohol-based hand rub solution. And to wear mask is something also very important, especially for the health professional who will be exposed when they do some treatment. But again, remain within your scope of practice. And that's really the most important. Don't try to improvise your competence. Remain within your scope of practice. And as we learn from you in the field, from all of us in the humanitarian activities, the task shifting is something that can be done, but it means that we are working under supervision of very experimented persons.
Thank you. Well, as we just start to wrap up, this has been a very interesting, very insightful presentation. Thank you, Lionel. Thank you, Olivier, for your contributions, and Nema. One of the last questions that popped up here, I think, is very poignant. And it is, if no ventilator and no oxygen, then what? And the reality is this is a true scenario that I have experienced as a physician overseas, and many people online probably have as well. So what I'd like to do to close off this session is just give each of our panelists, Lionel, Nema, and Olivier, just a few words to encourage and some pearls of wisdom to people who have no ventilator, have no oxygen, then what? So thank you, Ahmad, for that great question. And Lionel, let's start with you.
Yeah, thank you, Dr. Zurmatia. I saw the question, and I wanted to. It's a good one for finishing. Yes, if you don't have ventilator, at least you cannot do harm to your patient, and it's already a good news. If you don't have oxygen, this is not a good news, but you can improve oxygenation without oxygen by using this prone position. And I can send you all the literature concerning this, and you can see that you will, you can improve. For example, you have a patient coming with 75% of oxygen saturation. You put the patient on prone position, and you can increase the oxygen saturation until 92, 93% only by improving the ventilation perfusion matching. And that is just basic physiology. You know, we are talking here in this room without oxygen. We have oxygen from the air, of course, but we don't have supplemental oxygen. And if we go to altitude, we can go as high as 5,000 meters, even as high as Kilimanjaro Mountain, nearly 6,000 meters, and we will not die. So I mean, if we don't have ventilator, we will, in any case, not intubate the patient. If we don't have oxygen, we could put the patient in prone position. And if we don't have anything, and if the patient don't want to go in prone position, that does not mean he will die. He can stay for several days, hypoxemic, sure, but it doesn't mean that he will surely die. When you have a flu and you stay home, I am sure that many of these patients or all patients staying home are hypoxemic, but nobody knows because nobody measured that. And that doesn't mean that all the patients with the flu just die. So I think we can still do something and still have hope, even if we don't have ventilator and even if we don't have oxygen. I hope you get my point and my message. Olivier.
I will try to be gentleman, and Nema first, please.
Yes.
Oh, that's an excellent comment, and quite profound, because that's the situation we are in. So 2 ventilators for a population of 1 million, and more than 90% of the facilities here in CIA do not have oxygen. More than 95% don't have pulse oximeters. So that's the situation we're in. And for me, the solution is prevention and containment, and so that we can prolong that influx to the health system and save as many lives as possible, because there's no way we will save lives if we let the virus run its course. So the solution here that we are adapting is basically really raising awareness, educating the communities, making sure that everyone is wearing a mask, making sure that everyone's washing their hands. So prevention, containment, and if you still get sick, then yes, we will put you in a prone position, but we don't really have oxygen and we don't really have ventilators.
Thank you, Nema. And I think, yeah, you know, when we speak with limited resources, quite often people think about Africa. I was in Ukraine, non-governmental control area, a few months ago, in the beginning of March, and as you know, it's an ongoing armed conflict over there. And they are also with limited resources. And even in a hospital, in a city hospital, you had patients who were intubate, ventilate, but without any monitoring. And in fact, you had also within the whole hospital, any gasometer with the whole intensive care for adults and children. It means that they went through the intubation and ventilation, but without monitoring what they were doing. And that's not something that needs to be done to work with limited resources and try to do, but without control what we do. The problem is, do we want to go to minimum standards or do we want to go to best practice? And that's the big challenge. Minimum standards, it means that you need to follow the guidelines, guidelines given by WHO, by literature, by organization. And sometimes when you are in the field, you know that you are under the minimum standards, but you see that you can do something. And your goal is to reach and to be above the minimum standards as soon as possible. And that's why, for me, the best practice in such kind of situation is obviously, as you mentioned, Lionel, is to put the patient in prone position. And most probably, the patient will find by himself the appropriate position, because as you know, when we see a patient with a acute asthma crisis, patient will be in a sitting position. We'll put a little bit his thorax in front of it, in front, and because he will realize by himself that in fact he can breathe easier when he is in this position. Then I support completely your recommendation, Lionel. Is just the only thing that we can do is just to advise the patient to put in prone position. But again, in a disaster, because we are still in a kind of disaster, in a major health crisis, in this pandemic, we cannot save everyone. We need to know that we will do our best with limited resources. When we have plenty of resources, we can do a lot. But when we have limited resources, we do as much as we do, but with what we have, what we have. That's my comment and my answer.
Well, thank you very much. And I think with that, we'll close off this session. And I just want to give a very special thank you to all our panelists, Dr. Dumont, Dr. Hagen, and Dr. Kaseja, particularly Nema for joining us all the way from Kenya. Very special, glad to see you. And I hope you keep safe and really commend you for the great work you're doing with your community down there. So to all our participants, thank you very much for your comments. There will be a video recording of this that will be available online afterwards. If there are any questions, please email us for links and questions. And thank you very much. So from all of us at UNITAR and the Global Surgery Foundation, the University of Geneva, and Second Chance. Thank you very much for joining us, and have a great day.